All right, going on to the next presentation, we have Michael Sherer, who is presenting on protocol for a prospective trial to assess novel contouring education intervention for radiation oncology residents using an interactive online platform.
All right. Hi, everyone. My name is Michael Sherer. I'm a PGY3 at UC San Diego, and I'm really excited to be here and would like to thank the organizers for inviting us to present our protocol. So the motivation for our project comes from a wealth of data that shows that variations in contouring are common and that this has important consequences for our patients. So here's data from a meta-analysis of multiple cooperative group trials across different disease sites. And you can see that patients who had deviations from the trial-specified radiation protocol actually had a significantly worse overall survival. And this sort of data has led to a lot of interest in contouring, quality assurance, and trials are now implementing programs such as this EORTC trial for head and neck cancer, where institutions have to submit a benchmark case and show their contours before they start enrolling patients. But as you can see, even in 2021, contouring variability is a significant problem with high rates of unacceptable delineation for both OARs and target volumes. These data naturally raise the question of how radiation oncologists are taught to contour. And in the US, the dominant method is the apprenticeship model, where residents are paired one-to-one with an attending who provides guidance and feedback on contouring. This system depends on a few things: the expertise of the attending, the number and type of cases that are seen during the rotation, and the time that's available for teaching. And there's a recent survey of US residents that shows the sometimes inconsistent results of this system, with a significant number of residents reviewing contours with their attending half the time or less. Of course, there are other resources out there. There are consensus contouring guideline papers, of which publication has been rapidly increasing over the past few years, as seen here. But guidelines are sometimes difficult to translate into clinical practice, and most aren't targeted at a trainee audience. Our group developed eContour, which addresses many of the limitations with current resources. It allows for 3D visualization of expert contours. And we've shown in a randomized trial that it helps improve resident contouring skill. But even eContour is not interactive. There's no way for residents or anyone else to submit contours and receive feedback. And so this unmet need for improved contouring training resources led to our proposal, which is to standardize and improve the contouring curriculum using a novel interactive platform with real-time feedback. We're going to do so focusing on 3 disease sites that are among the most difficult to contour: head and neck cancer, GYN, and GI. So the first intervention will be educational modules for residents to use during a rotation in each of these disease sites. Separately, we're going to develop a contouring assessment tool that can be incorporated into exams, for example, at the end of a rotation. And then finally, we'll formally test the effectiveness of both of these interventions in a multi-institutional randomized trial. The educational modules will be built using the iContour platform, which is being developed at UCSD. And as you can see, it allows users to submit contours and then receive immediate feedback about how they compare to expert contours of the same case. In addition to geometric feedback, we're hoping to, of course, incorporate dosimetric feedback so you can see the effect of the contouring on target volume and OAR doses. We're going to build 3 modules for each disease site. So for GI, for example, you could have a rectal module, esophageal, pancreatic, and residents will use those during the rotation. Each module will highlight recommendations from relevant published literature and then give the trainee a chance to practice applying those in real time. We're going to pilot this at UCSD and then improve it based on the feedback we get before starting the trial. The next phase is a contouring assessment tool. So at UCSD, at the end of each rotation, we take mock oral type examinations and are often asked to describe volumes that we would contour for a particular case. However, even if someone can rattle off the checklist for, say, all the components of the intermediate risk CTV and nasopharyngeal cancer, that's a very different task than actually being able to identify and outline those areas on a simulation scan. And so we think this platform will allow for a more clinically meaningful and fair assessment of contouring skill. We'll request 1 to 2 specific tasks, and we'll provide feedback both to the resident and the attending with the goal of stimulating formal discussion regarding contouring. Once again, we'll have a pilot phase at UCSD and then refine them as needed before starting our trial. here's the schema for our randomized trial where we're going to be able to formally assess the efficacy of both of these interventions. So we'll start with a baseline contouring assessment before the rotation starts, and then there'll be 2 randomizations. So first, we'll have eye contour modules or not, and then there'll be a secondary randomization for the end of rotation contouring exam or not. Our primary endpoint is a confirmation index between the resident contours and expert contours. And based on data from our prior e-contour trial, we expect each intervention to improve the confirmation index by 0.1. And so to adequately power our study, we're going to need about 40 participants. Of note, we're delaying the final contouring assessment to 2 to 3 months after the end of the rotation and all the study interventions. This is so that we can assess not just short-term knowledge recall, but durable improvement in contouring skill, which is needed if our interventions are ultimately going to affect clinical practice once residents graduate. We hope that both of these platforms will prove to be successful teaching tools, and it'll provide a uniquely evidence-based way to teach contouring. And one advantage of the online format is that it's easy to expand. So we can add new disease sites, cases, exams, and we can distribute to more programs in the US and even beyond. And as we've seen with eContour, there's global demand for contouring resources that are effective and user-friendly. So we're hopeful this project can ultimately achieve a similar impact. In order to recruit 40 participants from around the country, we'll obviously need some help. And so if you or your institution would potentially be interested in participating, please feel free to slide into my DMs, email me, tweet me, or you can even scan this QR code and that'll just let you fill out your email. I'm happy to discuss logistics, make sure we can recruit and run this trial effectively, and then I'll reach out to everyone when formal enrollment is open. And I'd like to thank everybody involved in the project, especially Dr. Murphy and the program leadership at UCSD. And thanks again to the organizers for allowing us to present our project.
Great job, Michael. Loving to see more prospective randomized work in this space. Hard to do, especially with the size of residency programs as they are. You know, I just wanted to comment, I really like the idea of doing your assessment months after the rotation. One thing that I've always noted is, like, of course, I remember things very well the day after I've learned it all, but the retention is always a question in medical education that I'm glad that you're assessing. And the phase 2 aspect of your project, where you're having trainees show, not just say, I think really addresses the higher levels of assessment, like in Miller's pyramid, shows how as opposed to just telling how. So great things all around. I have a question on the gold standard contours. Like, how did those get developed?
Yeah, that's a great question. So we have the eContour expert team who curates the cases that are available on eContour. So that'll probably be the main resource for kind of accessing the experts to contour those cases. I saw a request in the chat to put the QR code back up, so I'm just leaving that slide up.
And those are multi-institutional, I take it. I know certain institutions have preferences that not everyone does.
Yes, they are multi-institutional. Even then, it doesn't, you know, obviously there is still some subjectivity in contouring that we're never going to be able to get rid of, even with an expert gold standard.
So this is Dan. Sorry, there was one question in the chat from Matt Spraker. I don't know if you caught it for the moderators.
Yes, yes, the comment was, you know, those papers imply that the contouring deviations associated with reduced survival are quite large. Can you expand on how you chose your endpoint?
Yeah, so when we did the randomized trial of eContour, we looked at this confirmation index, which may not actually be the most clinically meaningful way to measure contour overlap because it doesn't account for example, the dose distribution around a particular structure. And I'm actually, one thing I'm looking at interested secondarily is kind of more advanced metrics for defining overlap. But since we have the data from eContour kind of showing how much that improved the confirmation index, we can use that as a baseline for our sample size calculations. So that was our primary motivation in using the confirmation index.
Then there was a comment of any interest in or plans for taking this assessment outside of just training, possibly in the continuing medical education space.
Yes, definitely. It's so the my PI, Dr. Murphy, has funding from the Agency for Healthcare Research and Quality, and his main aim is among practicing physicians. A similar idea. And so this is kind of the educational aspect of it, but we definitely also are looking at it in the attending CME setting.
Dave, do you have any comments?
No. I agree. Some really interesting work there, and I do think that contouring is one of those areas where, as already mentioned, small changes can result in big differences potentially. So a bit of a frontier. There's also some comments there about other work which has been done there in places internationally. I'm not familiar with all of them, but it'd be good to sort of see what collaborations might be able to be done there.